proposed error, how do this develops? How do the extrophy epispadias complex develop? It is due to the abnormal overdevelopment and the persistence of cloacal membrane. This prevents the normal mesenchymal migration, and due to this, the cloacal membrane becomes unstable and it ruptures prematurely. So, if the cloacal membrane ruptures before the urorectal separation, that is between 4 to 6 weeks, it leads to cloacal extrophy. If it ruptures after the septation but before mesenchymal ingrowth, it leads to classical bladder extrophy. And if it ruptures after mesenchymal ingrowth, it leads to epispadiasis. Then comes the role of P53 gene. It is a transcription factor that is critical for stratified epithelial development, that is skin, bladder, and prostate. And its expression is decreased in the bladder extrophy. And in the animal model, P53 knockout has been tried, which leads to CB-like anomalies. And polymorphism in the delta and P63 gene, which is the isoform of P63, is associated with reduced expression and may contribute to extrophy epispadias pathogenesis. So, extrophy epispadiasis complex results from the combined defect in the P53 gene and local mesenchymal defect. So there are several associated anomalies. It is not only the bladder problem. So it involves a spectrum. It involves various systems like urogenital, in which bladder, urethra, and genitalia and upper tract is involved. Musculoskeletal system, in which pelvis and abdominal wall is involved. GI system is also involved, and neurospinal system is involved, especially in the cloacal extrophy. So we have to learn about the involvement of each system so that we can plan the further surgical care. First, we will be learning about the urogenital anomalies. In the bladder plate is often exposed with polypoid mucosa. And on the histopathology, we will see the immature and fewer myelinated nerves. It has growth potential after closure, and we have to delay the primary closure if the template is less than 3 centimeter and if it is covered by polyps or it appears inelastic. In the urethra, there will be epispadias, which is the dorsally open along the entire penile shaft, or in the female, there will be patulous meatus. The bladder neck is usually incompetent patulous, which leads to the incontinence. Then coming to the upper tract anomalies, it is present in 33% cases. Examples are horseshoe kidney, ectopic kidney, utero-pelvic junction obstruction, and it is more common in cloacal extrophy. VUR, it is seen in 100% of cases due to lateral and abnormal urethral insertion. And post bladder closure, there is 100% incidence of VUR. So we have to do the surgery of VUR also, which can be done in the subsequent stages. So we have to reimplant the ureters. The penis is short and broaded, and there will be dorsal chordae due to the dorsal corporal bodies, and corpora cavernosa are splayed and attached laterally under the pubic rami. Urethral meatus is dorsally located, which can be located anywhere from pinopubic angle to the proximal glands. Scrotum is often bifid with lateral displacement, and in cloacal extrophy, the phallus may be completely bifid with halves of unequal size. In the females, the mons pubis is usually flattened and laterally displaced. Clitoris is bifid, located within the anterior vaginal wall, and vagina and introitus are shortened. Vagina may be stenotic. It is anteriorly displaced introitus is there, and associated anomalies are duplication, septation, and agenesis of uterus or vagina. Urethra is dorsally open, and there is patulous bladder neck. Musculoskeletal anomalies. The bony pelvis, the hallmark feature is there will be the distance between the pubic symphysis is increased. It is normally it is 1 centimeter, but in these cases it is approximately 4.8 centimeter. And we can and in the pelvis, the anterior pelvis will be shortened by 30%, and there will be external rotation of the posterior segment, and there will be retroversion of acetabulum and wider sacroiliac joint angles. So it creates a waddling gait, and which creates a mechanical challenge for bladder and abdominal wall closure. So before closure of bladder and abdominal wall, we have to do the osteotomy and restore the pelvic anatomy. So this is the anatomy we can see. This is the normal anatomy, and in the extrophy, the pelvis is exteriorly rotated, and anterior levator ani is shortened and flattened, and posterior levator ani is lengthened, and pelvic floor is usually flattened. So in this diagram also we can see the increased distance between the pubic bone and the flattened pelvis. When we do the MRI of the pelvic floor, we will find the levator ani complex is externally rotated, flattened, and positioned posterior to rectum. So it leads to the open book configuration of the levator ani complex. So this funnel shape in competent pelvic floor is primarily anatomical contributor to the urinary and fecal incontinence. In the cloacal extrophy, there will be similar thing, but there are more severe and asymmetric vascular anomalies. Abdominal wall and hernia, there will be abdominal wall defect. There will be triangular opening from umbilicus to the pubic, and the rectus abdominis will be diverse and inserted widely on the separated pubic rami. And there are high incidence of hernias. Umbilical hernias are very common, which are usually repaired during the primary closure, and indirect and inguinal hernia are also common, but they are repaired later on. GI anomalies are common to classical bladder extrophy and cloacal extrophy. There is anteriorly displaced anus and sphincter complex, which leads to the fecal incontinence. In the classical bladder extrophy, there may be omphalocele, imperforate anus, and rectal prolapse. And in the classical cloacal extrophy, omphalocele is always present. Imperforate anus is also nearly always present, and other anomalies are malrotation, short gut syndrome, hindgut remnant, which this separates the bladder plates into the two halves. So this is the male anatomy, male cloacal extrophy, and in this we can see the omphalocele, and here we can see the two halves of bladder. Here we are able to see the cecal plate and intussusception. And this is the female, which in this we can see the divided labia and clitoris. Neurospinal anomalies in the epispadias and classical bladder extrophy, there are less incidence. In the classical bladder extrophy, approximately 7% cases may have spinal anomalies. Example, spina bifida occulta. And in the cloacal extrophy, more than 90 to 100% cases have major neurospinal defects, which includes myelomeningocele, tethered cords, spinal diaphorism, and hemivertebrae. So the implication of this is we have to do the neurosurgical consultation, and we have to treat each defect accordingly, because it also impacts the bladder and bowel function and ambulation. So for diagnosis, it can be diagnosed on the prenatal ultrasound. Gestational period is 15 to 32 weeks, and it is can be diagnosed in most commonly in second trimester. The clues on the ultrasound are persistent non-visualization of the fetal bladder, and lower abdominal wall mass, that is extrophied bladder, and low set umbilicus, and the widened pubic rami and abnormal genitalia. And pathognomic feature is we can see in this ultrasound. This is the bladder plate, and this is the prolapse ileum. So this is the pathognomic feature. It is the elephant trunk sign. So this is the elephant trunk sign. Postnatal assessment. it is obvious on physical examination. We can do the physical examination and determine whether the patient is having epispedia or cloacal extrophy and classical bladder extrophy. And immediate neonatal management is we have to protect the bladder plate. So bladder plate is covered by sterile, non-adherent plastic wrap. We should avoid gauze because it causes trauma to the bladder mucosa. And initial workup is we have to do renal ultrasound to rule any further anomalies, echocardiogram, spinal ultrasound, especially if cloacal extrophy is suspected. And single most important is we have to refer the patient to the specialized tertiary care center, which are having the multidisciplinary team for the management of extrophy epispadias complex. So why centralized care is important? Because high volume centers have significantly better outcomes. So the multidisciplinary team it comprises of pediatric urologist who is the leader of the team. It comprises of pediatric surgeon who will treat omphalocele and GI issues. It comprises of pediatric orthopedics who will be dealing with the pelvic anomalies. It comprises of neonatologist, pediatric anesthesia, and nephrologist, neurologists, and various other uh, specialties. So, EUA guidelines, there is no dedicated guidelines for the management of extrophy epispadias complex. Management is mainly driven from the expert consensus or the specialized center. So, for neurogenic detressor activity, antimuscarinics are recommended. For viewer, we have to treat the bladder dysfunction first, then we have to do the reimplantation of the bladder. And CIC is strongly recommended for incomplete bladder emptying, and bladder augmentation is for the bladder augmentation patient. You have to do the routine surveillance, which includes ultrasound metabolic panel and vitamin B2, B12 checks. Key papers and contributors that shaped the modern management. So these are the several papers which shaped the modern management of the extrophy epispadias complex. And now coming to the surgical management. So the overall goal is we have to restore the we have to do the functional reconstruction in the stages. In the stage one, initially we have to address the bladder abdominal wall and we have to do the pelvic closure. It is usually done in the newborn period. And epispadias repair is usually done in 6 to 18 months, and bladder neck reconstruction and anti-reflux surgery are usually done later in 4 to 5 years of age. So stage one is initial closure. It is ideally done in first 72 hours of life because there is advantage of maternal relaxin, and due to this the pelvis is pliable. So the surgical principle is we have to do the tension-free closure, and osteotomy is done to which closes the pubic diastasis, reduces abdominal wall, pelvic floor tension, and positions bladder back into the deep into the pelvis. Uh, there are two types of osteotomy. One is anterior approach, and other is posterior approach. It is more powerful than anterior, but less commonly done. And after the osteotomy, we usually apply the Byron traction or spica cast for 4 to 6 weeks. Then in the second stage, we do the epispadias repair. For male epispadias, the objective of the epispadias repair is release the dorsal body. We have to reconstruct the orthotopic urethra and achieve good cosmesis. And there are two main procedures which are defined for epispadias repair. One is the modified Cantwell-Rensley repair. This is the gold standard. In this, we deglove the penis and we create the urethral plate and we the corpora which are lying posteriorly to the urethra. We rotate and approximate the corpora cavernosa over the neo-urethra. The Mitchell process, in this we do the complete penile disassembly. We radically separate the urethral plate, corpora, and hemiglans, and then we do the reconstruction. So this is modified Cantwell repair. So in this, we can see the corpora are lying posteriorly, corpora cavernosa, and first we make the neo urethra, then we give the Rensselaer incision in the corpora. Yes, and then we do the reconstruction. In the Michel process, this is the radical. We do the radical separation, and then we reconstruct the urethra. So for achieving incontinence, we have for achieving continence, we have to do bladder neck reconstruction. So for this prerequisite is the bladder capacity should be adequate, and the classical technique is young D's Ledbetter technique. It creates a muscular tubular bladder neck from posterior bladder slip, and it is often combined with bilateral ureteric transplant for VUR. So this is uh, young lad COVID technique, and we do the denuding and use the posterior mucosa to reconstruct the bladder neck. uh, when salvage and ejecting procedures, when the primary goal fail for poor bladder capacity and growth, we can do the augmentation cystoplasty, in which we can use the stomach, ileum, or colon. And for failed BNR intractable consistence, we can use the bladder neck sling, artificial urethral splinter, and and we can also do the bladder neck closure with continent catheterizable channel, that is Mitternoff procedure. Definitive diversion is done in extreme cases in this cystectomy with ileal conduit or continental pouch. So, management of cloacal extrophy, it is usually a surgical and medical emergency because every organ is lying outside the body. So, we do the staged approach. On the day one, we stabilize the omphalocele, protect the bladder, hindgut plates. We do the neurosurgical evolution of meningomyelocele, and uh, in the initial days, day 2 to 5, we separate the GI, gastrointestinal and urinary tract. We do the colostomy, we do the bladder closure and omphalocele repair. And in the further stages, we do the repair of epispadias, bladder, we do the bladder neck surgery, we do the genital reconstruction, and we manage the short gut and spinal issues. Survival is now more than 90% in the centers of excellence. Complications, early complications are wound dehiscence and bladder prolapse. This is the most feared early complication. It is often due to the repair under the tension. Then other complication is urethral cutaneous fistula. It is common after epispadias repair, urethral stricture and metal stenosis, and osteotomy related complications are there. Persistent incontinence is the most common long-term challenge. Upper urinary tract deterioration, it is due to the high pressure storage, recurrent pyelonephritis and VUR. Bladder and reconstruction calculi are common. Metabolic complications are there because of the bowel defect, due to vitamin B12 deficiency also, and there is increased oncological risk. Therefore, lifelong surveillance is important. Fertility in the males, of males have normal spermatogenesis, but ejaculatory dysfunction may be there and may require the ART. And the females can conceive, but the pregnancy is usually high risk and delivery via C-section is recommended. Sexual dysfunction, erectile function is often preserved in males, and dyspareunia may be possible in females due to vaginal stenosis. Psychosocial health, body image, self-esteem, depression, anxiety are major concerns. So we have to give psychological support. And the transition to the adult. So the problem is the pediatric urology team and pediatric team often manages the case, but in the adults, the adult are usually lost to follow up. So we have to follow up the patient in the adult age also. And the solution is a structured transition clinic. It involves pediatric and adult reconstructive urologist, nephrologist, and gynecologist. And there should be formal transfer of records of the patient for the further care. So the adult urologist role is to manage the late complication, incontinence, stones, and perform urinary diversion if needed. So the 10 commencement of ectopia pisidias complex is first is the centralized, the care should be done in the high volume center. We have to protect the bladder, which is the most important, and it should be done with plastic sheet, not the gauze. First closure is the best chance for success, so we have to do it well. Use osteotomy liberally to achieve the tension free closure, which is also very important. We have to do the continence surgery. Before continence surgery, the bladder capacity should be adequate. Vitronov channel we can use, which is a powerful tool for continence and ease for catheterization. Never neglect the genital reconstruction. It is very important for psychological support also. And we have to screen and management neurospinal defect aggressively, especially in the cloacal extrophy. We have to plan for lifelong transition care from birth to the adulthood, and we have to prioritize psychosocial health. Conclusions, extropia epispedias complex is a complex multi-system birth defect which requires lifelong and specialized care. Modern stage functional reconstruction can achieve excellent outcome. We can preserve the renal function, social continence, functional criteria, and success is highly dependent on the technical excellence and compassion and multidisciplinary approach. And the journey starts from the delivery room, actually from the prenatal period and till the adulthood. Thank you.
Thank you, Ashish. And so, do we have anybody from outside joining? Okay. So, thank you once again, all residents and faculty. And again, the same thing. Any comment, any query, most appreciated, most welcome. And so, I think Dr. Govind and then, okay, fine. So again, the same routine we will follow. I will briefly summarize the whole thing. Then we will have MCQs. And then if you have any query, just let me know. So we all know this complex, extrophy epispadias complex, is a spectrum of disorders, right? Spectrum. It begins with the most mildest variety, granular epispadias, to the most severe variety, that is cloacal extrophy. And again, it has a spectrum of anomalies associated with it. It's not just the urinary tract, it's the anti-abdominal wall, the pelvic bone, the spine, and even there may be undescended testes, there may be hernia, omphalocele, bowel involvement. So it has a spectrum of anomalies associated with it. And that makes it a most challenging surgery, I think, we come across, because it's not just one surgery. It may require multiple surgeries almost throughout the life of the patient, and still the patient may not be completely normal, right? And it involves, again, multidisciplinary team, right? So it involves pediatric surgeon, it involves gynecologist, general surgeon, and psychotherapist, and everything. We all know it. The first known extrophy was about 2000 BC. So it's a very well-known anomaly since the time immemorial. And about a century ago, the first surgery of extrophy was done by Trendelenburg, right? So Trendelenburg is known for so many things. Because I will give you just, we can have these people who have enormously contributed to urology. They should be put as photographs, and their contribution should be, I think we should do it. So later,
even if we, sorry,
yeah,
even if all of us just write about one scientist,
yeah,
we can also publish a book about it.
Book
and
about
it will be very well received. And I mean, there are so many contributions that when we read, we get to know. I mean,
Yeah.
that day we were talking about Alsted. Alsted और उसका पता चला कि peroxisome के ऊपर and so many intracellular organelles के ऊपर work.
So Ashish, you just डॉक्टर नचिकेत के साथ में बैठकर you just can have a number of a few scientists. We can ask some of our residents uh, to contribute on each one of them. So again, then this surgery was uh, then again it could be a kind of a multi-stage surgery. It could be a single-stage surgery also. So we had workshops on extrophy bladder where we had invited Dr. Kuril, and he's famous for his single one-stage surgery. So MSRE is the modern staged extrophy repair, and CSRE is the complete primary CPRE, complete primary repair of extrophy bladder in one stage. As he said, we all know the first, and what you said about osteotomy, we can even do away with osteotomy if it is done within 48, 72 hours, because the bones are pliable and you can actually bring the symphysis pubis closure without doing an osteotomy. But it's unfortunate that we do not get these patients within 72 hours, or they are not operated within 72 hours, majority of them. So that is why osteotomy is a part of the surgical management. And we all know that we have also been doing osteotomies. I remember it's not just innominate and the posterior iliac, but even pubic osteotomy is not. So we do pubic osteotomy on both the sides, bring the two pubic bones together, and that is also possible. Even Kuril also does in that osteotomy. So definitely the evaluation, the history of the patient, again important. We have been through the embryology. Just you have to remember that is an abnormal development of the cloacal membrane and the cloacal septum, which actually divides the cloaca into the anterior urogenital sinus and the posterior anorectal region. So this premature rupture of the cloacal membrane or abnormal development with a wedge effect, sometimes they say, results in all these variants of extrophy bladder. Nowadays, there is again another view that the genital tubercle is responsible for this. And to begin with, it is the pubic diastasis, which results in all anomalies. So if you see, the first thing that is there is the pubic diastasis. And probably that pubic diastasis is the main initiating factor which results in a extrophy bladder. And the management part and the diagnosis part, it's very kind of obvious. We need to diagnose the various variants of extrophy complex. And prenatally, as I said, there are a few clues which can tell you whether this is extrophy bladder or cloacal. That elephant trunk deformity is in cloacal extrophy. It's not an extrophy bladder as such. And this is cloacal extrophy is an emergency because there's an imperforate NS. So you have to do immediate colostomy first. And a colostomy has to be done. So it's an emergency. In the management part, again, because this is a rare variety, it's 1 in 50,000, right? It's a very rare kind of anomaly. And boys are more involved, at least twice the females. In females, you have to understand that there would be a bifid clitoris and epispadic urethra, and rest of the things are same. We must remember the pelvic abnormalities. What are the different pelvic abnormalities? The most common and the prominent one being the pubic diastasis, where the distance is around 4 to 5 centimeter. Normal it is 1 centimeter. But as the boy grows older, the diastasis becomes even more. It is around 10 centimeter. It becomes even more. And then the NTS segment, the shorter NTS segment, the outward rotation, and wider sacroiliac joints, and all those things, and the retroversion of the acetabulum, all those pelvic anomalies. Then the musculoskeletal anomalies, muscle anomalies, So all these are part of the whole spectrum. So definitely this managing this is definitely very challenging. And as I said, most often we use the staged procedure where we actually repair the bladder and the epispadias first. And at 6 to 8 months, we will repair the whole epispadias. And around 3 to 5 years, once we get the bladder capacity adequate, because of the bladder and urethra closure, there is usually cycling of urine in the bladder, and the bladder volume increases. And once it is more than 100 ml, then we actually do the rest of the repair. That includes bladder neck reconstruction, ureteric reimplantation, genital reconstruction, or sometimes even augmentation, cystoplasty if the bladder capacity is low. So even after that, the chances is that at about, I think, more than 50% of patients may have some degree of urinary incontinence, and that may require other ancillary procedures. I think that was, in brief, the summary of extrafew bladder, and maybe we will be doing one workshop quite soon. Maybe in the next month, we are planning, and definitely you will be able to see each and every step, because Dr. Kuril does everything in one go. It takes around 10 hours, 8 to 10 hours surgery. So thank you. So all of you, you can just go to the MCQs. Anybody has any query? Any comment? Dr. Nachiket, you want to say? Come.
Sir, exam mein, I remember it used to be asked about the management as soon as the delivery of the child. So one thing for exostrophy, I remember that it's also used to be written in the text is that you should never clamp the umbilicus and the placenta, the umbilical cord with a clamp.
Yeah.
This is because the clamp can irritate the plate because the plate is coming up till the omphalos. Yes. So एक चीज ये मुझे याद आ रही है that you should only use a suture in the cases of omphalocele. And as you said about the gauze, it's important that you should not cover it with the gauze because gauze become dry. And then once you pull the gauze, so what will happen is that it will cause, abrasions on the plate. So as you said that you can use that saran patch, but you can also use even Gelunet and all. And the second thing that I want, if you're, as Sarah said, if you're planning to close it in 72 hours, which is the ideal time, then one question that used to be asked is that how do you know that the bladder plate is adequate? So the bladder plate has to be 5 ml. So one test that you used to do is that if 5 ml is equivalent to the thumb, if you look at your thumb and put it on a spoon, 5 ml teaspoon, then this is 5 ml. So you just push the plate. The plate has to go down, and then the margins of the bladder, they have to go around your thumb. So that used to be the crude indicators. These are just questions that I remember from exams that I used to be asked. And fecal incontinence is also very common in exostrophy epispedias. So that's why if you're planning to remove the bladder ka follow-up is also important. You have to see whether the bladder plate is hyperplastic, if they are polyps, because exostrophy epispedias is one of the variants in which you can later develop an adenocarcinoma of the bladder. So that's why if you see some polyps, then they can be more commonly 99% of the time they are hyperplastic, but always take a biopsy if you have any doubt, because there can be some remnant of, there can be some dysplasia in the tissue. Secondly, I remember is that if you, once you do the thumb test, then it's always prudent to do it under general anesthesia. Then only you'll understand whether your thumb is going below the rectus, which is diversified. One other thing about the anterior innominate osteotomy is that it used to be most common as you done, but it was common because it was easy. Because once you are going intra-abdominally and you're removing the colon, reflecting the colon on the right, reflecting the colon on the left, looking at the ureter, looking at the vessels, the iliac vessels, then the only thing that is left is the bone. So that's why as we were, more comfortable looking intra-abdominally inside the iliac bone, so that's why it became more common. But however, posterior, as you said, was the most robust, and but it was not done. This is because again you have to go through all the muscle layers, the gluteus maximus, which used to be a big muscle, then the vascular sulci of the gluteus going from behind, and we're not familiar with that area, as he rightly said. Something about the incontinence. These people can also have, incontinence, fecal incontinence. So that's why if you're planning to do a diversion, then it's important that you see you have to do a load test. That is an oatmeal load test to see how much of he'll be able to the anal tone, how much is there. Clinically, also you have to measure the anal tone. One other thing that I remember is how do you assess the bladder capacity once you've closed the epispedias? Then sometimes just by closing the epispedias on account of increase inside the length of the posterior urethra and maybe a little bit of the bladder neck gets reconstructed. So that's why continence itself comes and you do not have to do a bladder neck reconstruction. And for that, you have to keep on assessing how you do a cystogram. That is also asked. Cystogram is very difficult just because again, they become incontinent. You just have to see the capacity. The capacity, what you said was 80 to 100 ml, which is correct. So the cystogram also, when you put the catheter, then you just have to put 1 or 2 ml inside the bulb, maybe, slightly stretch it at the bladder neck and then assess the capacity. And rest, I don't think I have anything to add. These are just things about the exam. Yes, you did not mention a very important step inside epispedias, which was the IPCAM step. IPGAM is absolutely the opposite of what you do magpie. If you see magpie and IPGAM, IPGAM is the reverse of magpie that you do for hyperspedia. So IPGAM is incise plate, glanduloplasty and meatal advancement. Because you have a situation which is exactly opposite the hyperspedias, you do a surgery which is exactly opposite of hyperspedias. So in hyperspedias, you do magpie, and this way you will do an IPGAM. So that is one thing. After Baki, we've discussed everything, and it's more of a theoretical thing that you might get to say.
Thank you, Nachiket. Very important practical points made out. I think, yes. So this polypoidal mucosa usually will appear if the patient comes at a later age, right? So it's not at the beginning. Beginning, it's a normal mucosa, bladder mucosa, when the baby is born. And then the squamous metaplasia may happen, and this it's not only, I think, squamous cell carcinoma can also happen in these patients. So it's good if it comes later, then we need to take the biopsy. And then again, a very important point made about the thumb test. It's not just the capacity, the volume, the elasticity of the bladder wall, because these patients usually come late, and the bladder wall becomes fibrotic due to chronic infection and all that. So if the bladder wall is not elastic enough, then the thumb test helps not only to measure the volume, but also the elasticity of the bladder wall, and whether this is going deep down uh, easily or not. So I think those points are really important. And I think anybody has any other query? Any other comment? Adi, I want to make any? No? So, okay, we can go to the MCQs. So, as a routine, we go to the MCQs. The first question is, according to the cloacal membrane rupture theory, the timing of abnormal rupture determines the severity of the complex, and the cloacal extrophy results from rupture occurring at which stage? After mesenchymal ingrowth, after urorectal septation, but before mesenchymal ingrowth, before urorectal septation, and after genital tubercle formation. C, right? C. So we all have gone through that embryology. So the urorectal septum actually divides these two. So before urorectal septation, and this actually happens, and the mesenchymal ingrowth, usually it prevents the medial migration of the mesenchymal tissue because the membrane gets ruptured prematurely. And as I said, genital tubercle formation is maybe a main initiating factor to the whole anomaly. So it usually occurs before there is a problem with the genital tubercle which actually leads to all these issues. So which of the following is the most consistent urological finding after primary bladder closure in classic bladder exstrophy? Detrusor overactivity, urethral stricture, vesicourethral reflux, neurogenic bladder. So we all know VUR is 100%, right? So that's the commonest. As you said about the detrusor overactivity, neurogenic bladder, that usually will not appear if the patient has an extrophy bladder, right? So once the bladder gets closed, then there could be some features of detrusor overactivity, or other variants sometimes may have, or a simple epispadias may have detrusor overactivity. Yes. The hallmark musculoskeletal abnormality in classic bladder that contributes to waddling gait and a surgical difficulty is acetabular dysplasia, pubic diastasis, spinal dysraphism, contracted pelvic floor musculature. So we all know pubic diastasis is the most common. So sometimes even when you close it, it later again causes results in diastasis. Um, so this waddling gait is due to that. We know there is a retroversion of the acetabulum. Spinal dysraphism can happen in 7% of classic extrophy, and where in a large number, 90% in cloacal extrophy. And pelvic floor musculature, again, the anterior segment is short, posterior, and the posterior segment is large. Right? Same thing as the bone. The gold standard surgical technique for male epispadias repair in extrophy epispadias complex is, again, we all know, is in epispadias. So epispadias repair, it is modified Cantwell-Ransley. So when we talk of extrophy, then it is MSRE, modern staged repair, which is the usual one. Though we can do even complete CPRE, complete primary repair of the extrophy. Which prenatal ultrasound finding is considered pathognomonic for cloacal extrophy? So he said elephant trunk site is for cloacal, and if it is just a simple classic extrophy bladder, then there will be pubic diastasis, absent bladder, or the bladder will never get full, and there will be a mass in the anti-abdominal wall and low set umbilicus. These are all findings of non-visualization of fetal bladder. I think that's it. Okay.
I think one other few things that were missing from the seminar, even though I came late, was the penis. There are a few measurements which are important, like the anterior corporal length, the posterior corporal length. There is an apparent shortening. There is not a true shortening of the penis. Then there were a lot of MRI studies which were done by a guy which is known as Silver. So Silver found out how much the posterior corpora they are widened. Maybe you could have added those important things, so you could have just.
Yeah, I think this is important, the genital aspect, because these patients usually, even after repair, they will have a shorter penis, right, than the normal. And that is due to the short anterior segment, the pubic diastasis and everything, which results in a shorter penis in these patients. Another very typical thing about extrophy and epispadias is, anybody? Very typical thing which doesn't happen in a normal corporal body penile. So in a normal penis, if you inject in one of the corporal bodies, what happens? It goes to the other corporal body also, right? So even if you want to do an erection test, you have to put one needle on the one side. And what happens in epispadias? There is no communication between the two corporal bodies. So if you want to do erection test, you have to put on both the sides. If you want to do erection test and erect both the corporal bodies. So it's very typical of epispadias extrophy. Right. So thank you once again. If you don't have any other comment, we will wrap up the session. And thank you, all faculty, residents, and all those who might have joined us today. Have a good day. Thank you.